Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hi, this is Dr. Nick Biasotto, your host of the podcast of the Medical Society of Delaware called Delaware Healthcare Reality. Today we have a guest here who will be discussing kidney diseases. But before I introduce our guest, I'd just like to give you a brief overview of what the kidney does. The kidneys perform several essential roles in our body. It's a filtration and excretion system, removing waste products and excessive water from the blood to form urine, preventing toxin buildup. It also is a fluid and electrolyte balancer, regulating water, sodium, potassium, calcium, and other electrolytes to maintain proper hydration and acid-base balance. It's also a blood pressure regulator, producing a chemical known as renin, and which activates the renin-angiotensin-aldosterone system to control your blood pressure. It also through a chemical called erythropoietin, it stimulates blood cell production in the bone marrow, and it also activates vitamin D to regulate calcium and phosphorus, supporting bone mineralization. So it's a detoxifier, metabolizing and excreting drugs, toxins, and metabolic products. Today, we have Dr. Prayus Tailor, who is a nephrologist, and he's going to talk to us about acute kidney injuries, but focusing more on chronic kidney disease, which I see a high prevalence in our society today. Dr. Prayus Tailor is MD, board-certified nephrologist, and the managing partner of Nephrology Associates, PA, in Newark, Delaware. He specializes in chronic kidney disease management, home dialysis therapies. Dr. Tailor serves as a medical director for FMC, Brandywine Home Therapies, and Transitional Start Unit, where he focuses on improving patient transactions from chronic kidney disease to end-stage renal disease, promoting home dialysis modalities. He previously served as a program director for the Nephrology Fellowship at Christiana Care Health System and as our president in the past, Medical Society of Delaware. He holds the academic title of Clinical Assistant Professor of Medicine at the Sidney Kimmel Medical College at Thomas Jefferson University. Dr. Tailor has spoken in national and international conferences on advanced patient-centered kidney care and innovations in dialysis delivery, reflecting his commitment to improving the outcomes and the quality of life for individuals living with kidney disease. Welcome, Prayus.
Thanks. Great to be here, Nick.
Great to have you. Okay, first, before we get into the chronic kidney disease, which, as I've mentioned earlier, I see much of in my office and in our community, let's talk about acute kidney injuries, something that may happen, and what are the causes of acute kidney injuries.
So when I think about an acute kidney injury, this is essentially something where the kidney function goes down rather abruptly. So there's three different categories I think of. One is pre-renal, so any insult that occurs before blood entering the kidney. Then there's intrarenal, which is a insult that's occurred within the kidney, and postrenal, which is something that's impacting the kidney function that occurs after the blood has filtered through the kidneys and is now being excreted as urine.
Can you give me a couple of the causes of pre-renal, intrinsic, and post-renal?
Absolutely. The most common cause of acute kidney injury is actually pre-renal acute kidney injury, and as you might expect, it's one where the patient becomes volume depleted, where they lose a lot more fluid and electrolytes than they should, and then that results in decreased blood flow to the kidney, and that results in a usually transient and temporary decline in the kidney function.
Like occurs with vomiting or diarrhea, correct?
Absolutely.
Mm-hmm.
And that can be compounded when you're on medicines that cause you to urinate more, like diuretics,
mm-hmm.
or if you're on certain blood pressure lowering medications that can impact your kidney's ability to cope in that situation, like ACE inhibitors and angiotensin receptor blockers. And, we've even seen it with some of the newer medicines that can actually help delay progression of kidney disease if someone's not keeping themselves well hydrated, like SGLT2 inhibitors. And for those people who are on these weight loss drugs and diabetic control drugs like GLP-1 receptor agonists, it's really important to monitor them as they go on these medicines and they start losing a lot of weight, because what I've seen is people develop acute kidney injury because they've lost a lot of weight, their blood pressure's come down, but yet they're still on all the same blood pressure lowering medicines, and what happens is they come in feeling dizzy and lightheaded and their kidney functions down and they're wondering why. It's just because we're really good at telling patients to take their medicines. We're not so good at telling them when not to take them, right?
Okay.
So,
all right, a little more on the pre-renal, the heart and the kidneys work in unison sometimes to keep the balance in the body. What conditions of the heart can bring on an acute kidney injury?
So when we see patients who have a decline in their heart pump function, like heart failure with a reduced ejection fraction, that can result in the patient developing fluid overload. That fluid overload kind of backs up into the kidneys and causes the kidney to have a reduction in its filtering capacity. And so what you need to do in that situation is do whatever you can to improve the heart pump function, but you also have to unload them. You need to get rid of some of that fluid, and that's where a lot of hesitancy comes in for different providers, because they're worried that adding a diuretic in that situation is going to make the kidney function worse.
Correct.
When in fact, in a lot of cases, it'll probably help.
Okay, understandable.
Yeah.
Now, I understand that renal artery stenosis, or narrowing of the renal artery, or blood supply to the kidney, is another pre-renal cause. How is that determined, or how do you make the distinction between other causes of the pre-renal events?
So, it's usually by the process of elimination.
Okay.
Renal artery stenosis is seen probably less commonly these days because of the advent of statin medications and medications to better control blood pressure. But usually I think about renal artery stenosis. In fact, I had a very interesting case, a woman who hadn't been to see a doctor in quite some time, and she came to me because over the course of 9 months, her kidney function had declined by over 50%. And she came into my office, her blood pressure was through the roof. And, when I was listening to her neck arteries and her groin arteries, I just heard
all kinds of
bruise and
all over, yeah.
And she was a heavy smoker, and my big concern was that her kidney arteries were narrowed. Her blood pressure was 220 over 150, and we had to send her to the hospital. Nonetheless, at that time, I asked for a CTA of the kidneys, or a angiogram of the renal arteries, and sure enough, she had narrowing of the kidney arteries, and they opened them up with bilateral stents, and her kidney function improved by about 30%, and her blood pressure's under better control. So
there was the cause of her blood pressure problem, probably.
Exactly.
Right? Okay.
Yeah. So it's not as common, but you have to be aware when you have a patient presenting that way.
Understandable. All right, let's talk about intrinsic. The kidney's been injured itself, not the pre or not the post. We're talking about the kidney itself. Talk to me a little about that.
So within the kidney, there's I think of 4 different compartments. One is the vasculature, or the blood vessels that supply it. Then there's where the filtration occurs, which is at the level of the glomerulus. And then there's the area in between. Then there's the tubules, which have cells that line these tubes, which further process your urine. And then there's the area in between all that, which is called the interstitium. And various medications can impact different compartments, but sometimes things occur out of the blue. Sometimes it occurs; these injuries occur as an allergic reaction to a medication, so that's a wide variety of things. But the key thing there is just basically taking a look at the urine.
So what will that show you?
Well, if you're looking at for a glomerular disease, you might. Well, so let me back up. If you have blood and protein in the urine, the things I'm thinking about are a glomerular disease or a vasculitis. If I don't see anything in the urine, it could be a tubular injury.
Okay.
Or you might see what's called muddy brown casts or granular casts. That could indicate a tubular injury. And lastly, if you're worried about an interstitial nephritis or an allergic reaction within the kidney, you might see white blood cells in the urine or white blood cell casts.
When you're dealing with the intrinsic injuries, they always warn us that people have to have a renal function that's reasonable before getting contrast dye. Is that another potential etiology for that?
So we, as nephrologists, we still believe in the identity of contrast-associated nephropathy. There's some radiology papers that suggest that that maybe it occurs much less frequently than initially thought, and that probably is true to some extent. We always exercise caution in our patients who have advanced chronic kidney disease when they are going for procedures that use intravenous or intra-arterial contrast. And basically what we do in that situation is to prevent an injury, making sure they're getting IV fluids before and after the procedure.
Why does a contrast dye cause this problem?
Well, it can cause the injury in a number of different ways, but first and foremost, it can cause an immediate constriction of the blood vessels that supply blood to the kidneys, so causing a vasoconstriction injury. And then the contrast is also directly toxic to those cells that line the tubules within the kidney.
Gotcha. Very good. All right, let's move on to post-renal, and then we'll get going. Then we'll go further on. But tell me a little bit of post-renal. That seems to be kind of obvious, but go ahead.
So this is when, there's typically a blockage to the outflow of urine from the kidney. So the tube that goes from the kidney down to the bladder is called the ureter. But the blockage could be anywhere from the ureter to within the bladder to the urethra. And there's a number of different things that could potentially cause that. In the developing world, when we would see women who had a post-renal type of acute kidney injury, the most common cause was a uterine cancer or a cervical cancer, where the cancer had expanded so much that it encased the ureters and caused the blockage.
Wow.
Fortunately, here we don't see that very frequently at all because of screening and because of treatment of HPV with vaccinations and whatnot. So it's not a commonality here anymore. But
well, in a man, we got a blockage in the prostate often too. Similar problem.
Yeah, I've seen that which is in the prostate enlarging is a very gradual process, and so many patients won't really feel much of anything as that's occurring over years and years. So whether it's due to just prostatic enlargement or prostate cancer, men may not know that unless they're watching for symptoms or getting testing done for, let's say, a PSA or something like that. But essentially, the treatment is you relieve the obstruction. In the cases that I've seen that have come to the hospital with an obstruction, usually relieving the obstruction either through insertion of a Foley catheter or a more definitive means, prostate reduction surgery of some sort, you can see a significant improvement in the kidney function. But if it's been going on for a long time, you may not see that much improvement, and the patient may be left with pretty advanced kidney disease.
Gotcha. Most of the time, though, acute kidney injuries can be reversed if the etiology is addressed and properly addressed, correct?
Exactly.
Okay. How about some genetic causes of an acute kidney injury, like Alport syndrome or something like that?
So the genetic causes, usually present to me as more of a chronic kidney disease.
Okay.
It may be considered acute because there might have been, especially if it's a genetic cause, genetic causes usually manifest in younger age, and younger patients are probably not getting their kidney function checked on a regular basis.
True.
They're probably not going to a doctor on a regular basis, so there may be a wide gap between one test and another test, like it could be 5, 6, 7 years, and it'll look like the kidney function went from normal to abnormal very suddenly because you have 2 data points.
Right.
But most of these things are going to present chronically. But that being said, we have definitely significantly improved ability to detect genetic kidney disease because genetic testing is so readily available now.
True.
We are starting to use it more and more in our practice to identify patients who have genetic causes of kidney disease.
Okay, like what do? You don't ask for a specific test when it comes to genetic testing. You just send a geneticist, because to be quite frank, that's an area I'm kind of a little behind on, is the genetics. I wouldn't know what test to order. Would you send them to the geneticist and say, we're looking for the cause of kidney disease, and let them take it from there, or do you know all these genetic mutations?
I don't purport to know all of that, but no, what's happened is companies that perform this type of testing have come up with gene panels.
Okay.
That will assess for a wide variety of kidney diseases. Mm-hmm. And the ones that, especially those with a known genetic cause, mm-hmm. are generally included in these panels. So one that we typically use will assess for probably over 100 different types of genetic kidney diseases.
Wow.
And, it's pretty cost efficient, for the test. It's, even if you had to pay cash, like $300.
Okay, not bad. So, all right, so in just a brief overview, you can address acute kidney injuries by addressing the cause, the underlying cause, and giving supportive care and correcting the abnormalities, and then looking into the genetics of all of this stuff. Interesting. Now, we're going to take a very short break before we come back to talk about what we're really going to get into here, is chronic kidney disease. So it's break time. We'll be back in a second.
Information about the Medical Society of Delaware can be found on our website, medicalsocieofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Hi, we're back from our break. This is Dr. Nick Biasotto, the host of your podcast, Delaware Healthcare Reality, sponsored by the Medical Society of Delaware. And today we're speaking with Dr. Prayus Tailor, a nephrologist in our area who is very good at what he does. And we're going to be talking now about chronic kidney disease. Earlier we spoke about acute kidney injury, but now we're going to talk about probably the more common of the things I see anyway in my practice is the chronic kidney disease. Chronic kidney disease is a progressive loss of kidney function over months to years, defined by a reduction in the filtration system of the kidney itself, or persistent kidney damage, for example, through proteinuria over a 3-month period. The causes can be many, and I'm going to ask you about some of the causes.
So the most common cause of chronic kidney disease is diabetes. As you know, diabetes is very common in our country and throughout the world. So kidney disease impacts about 1 in 9 Americans. Most of them don't even know they have it. If you have high blood pressure, which is the second most common cause of kidney disease, it's about 1 in 5. If you've got diabetes, it's 1 in 3.
That's amazing, and that leads to damaging the glomeruli, right? Is that how that works?
So
that's diabetes, right?
Diabetes usually impacts the filtering units of the kidney, which are called the glomeruli. If you were to do a kidney biopsy in those patients, that's where you would see the damage. High blood pressure or hypertension can cause similar damage. But there are kidney diseases that can cause damage to other parts of the kidney, like the tubular cells or the scarring within the area in between those areas. Mm-hmm.
And glomerulonephritis from possibly autoimmune diseases such as lupus and the like. Is that correct?
Absolutely.
Okay. All right. We took care of the acute kidney injury, and we're now talking about chronic. And can obstructive uropathy still be considered a chronic problem?
Yeah, absolutely, because that, again, is something that can occur over the course of many months to years. And the damage, if not detected early enough, can become chronic so that you develop scarring within the kidney. Mm-hmm. And so we can certainly see chronic obstruction, whether it be through the prostate or through a bladder cancer or something like that obstructs the flow of urine from the ureters into the bladder, or even a stricture within these tubes that come out of the kidney called the ureters. So there are many different causes of that could become chronic.
Okay. Then we have recurrent pyelonephritis. I mean, I see people that get kidney infections that it does real damage to the kidneys to the point where they become a chronic kidney patient. How about other causes, like how many people with osteoarthritis are using non-steroidals, like, non-steroidal meaning it's not a steroid being used. It's these medications such as ibuprofen and all the other ones out there on the market, and they just take them because their arthritis starts so bad. Kind of gives you a reason to say to them, you got arthritis, I can't help you out because your kidneys are not doing too well. What do we do? Do we use a low-potency opioid to keep them and make their life better or less restricted? I don't know. It's one of the things I wrestle with commonly. But tell me, do you see many autoimmune diseases for chronic kidney disease?
Autoimmune diseases are more rare than they are common,
Okay.
but we certainly see them.
Okay.
Lupus kidney disease is something that we see frequently, usually impacting a younger patient population. And we see other autoimmune diseases that involve the body generating antibodies that impact some portion of the of the kidney itself. In general, those are diagnoses that are made through blood tests or a kidney biopsy, usually both, and require significant amounts of medication that can suppress your immune system. So you want to make sure you've got the right diagnosis before you embark on a treatment plan, because there are risks and benefits to these types of medications, obviously.
Gotcha. Now, I have a couple patients who have amyloidosis. Discuss how that could cause chronic kidney disease. We know amyloidosis is a protein, and in multiple myeloma you may see a large amount of that too. Is that just causing a blockage within the kidneys or what?
With amyloidosis, as you mentioned, amyloid is a protein, and this protein can deposit in various different tissues causing damage. Within the kidney, you can see it deposit within the glomeruli, which are the little filtering units of the kidney. You can see it deposit within the interstitium, which is the area between the glomeruli and the blood vessels and the tubules. You can see it deposit within the blood vessels, and you can see it deposit within the tubular cells too, so all over the place.
Amyloid
and it can result
in
very significant kidney damage and even kidney failure to the point of someone needing dialysis.
Okay, thank you. Well, the genetic causes we briefly touched on in acute kidney injuries, but we have polycystic kidney disease. I've seen that in my practice, and a few. It's not like as uncommon as I thought it might be. And that, how does that work? How does polycystic kidney disease cause a chronic condition within the kidneys?
So, polycystic kidney disease, or autosomal dominant polycystic kidney disease, is a genetic mutation, which is not all that uncommon. We've identified two genes that are responsible for the development of this abnormality, which essentially results in multiple cysts or fluid-filled cysts developing on one's kidneys, and sometimes it can even extend to the liver and whatnot. But over time, these cysts grow and grow, and then they start destroying the normal kidney and can lead to progressive decline in kidney function and even the need for dialysis or kidney transplant.
They're candidates for it, right?
They are candidates for kidney transplant, and we see a number of those patients get transplanted because the good thing is most of the people that I've seen with autosomal dominant polycystic kidney disease don't have a lot of other medical problems. And so,
but
they tend to be fairly...
But it causes a lot of other medical problems, right?
It can. You can also sometimes see blood vessel aneurysms, particularly in the brain. So we always ask about a family history of brain bleeds. But I'll add that Delaware is in pretty good shape when it comes to polycystic kidney disease because our practice is a Polycystic Kidney Disease Foundation Partner Clinic.
Okay.
And that means that we have local experts in our offices that can treat people who have polycystic kidney disease, and we're up to date on the latest treatment options, and we'll be pursuing research opportunities in the future as well.
What is a tip-off? If somebody comes to my office, they have hypertension, right? Probably, right? Is their abdominal girth increased? Is that kidney disease so bad that it could cause all kinds of things like that? Or what's the tip-off?
Usually it's incidental, Nick.
Okay.
Usually someone's had a CAT scan for some other reason,
Okay.
And then the radiologist will comment, there's multiple cysts on both kidneys, suggestive of polycystic kidney disease.
I got you.
So we get a lot of patients that either completely asymptomatic and it was caught incidentally, and then the other thing is if there's a family history,
right,
and they know it, and then they have been identified as having abnormal kidney function.
Got it. Alport syndrome, interesting one. You have a hearing loss with that, don't you? And also a renal failure. Right?
So Alport syndrome is something that's becoming a little bit more heterogeneous. Traditionally, the teaching with Alport syndrome is that it presents with hearing loss and some blood and protein in the urine because the genetic abnormality causes a mutation in the structure of the filtering unit of the kidney, which is called the glomerulus, or the basement membrane, I should say, and that causes the leakage of protein and sometimes blood.
Okay.
But now what we're seeing is Alport-like variants that will cause someone to have maybe some protein in their urine and maybe some blood, but no hearing loss. So we're seeing a kind of a whole different variety of those type of syndromes, but genetic testing has made it much easier to figure out what's going on in combination with the kidney biopsy.
And the other, I guess, rarer ones are Fabry disease as one, and then just congenital abnormalities within the kidney itself, correct?
Yeah, I mean, the most common, renal congenital abnormality is usually vesico-ureteral reflux, which is where a child is born and the tubes that come down from the kidneys into the bladder that are supposed to be sending urine down will end up having reflux when the bladder contracts because the one-way valves at the bottom of those tubes as they enter the bladder are not working well or deemed incompetent.
Got it.
And that can, if not treated, or if the child doesn't grow out of it, which is what usually happens, can cause some chronic kidney damage.
Got it. Now, let's move on to the treatment of chronic kidney disease. This is very important. Obviously, I guess diabetes, you want really tight management of blood sugars. Is that true? And is there any other things that we have to consider in the use of controlling diabetes?
So, when it comes to treatment of chronic kidney disease, I think we can speak in generalizations. Some of the things that we may talk about may not be applicable to everyone with chronic kidney disease. It really depends on the type of chronic kidney disease you have or what caused it. But if we're focusing on diabetes, there are a few things we need to do. Of course, controlling the blood sugar. We usually aim for a hemoglobin A1C of less than 7%. We want to control the blood pressure, generally aiming for less than 130 over 80 at all times. We want to make sure that they're on the right medicines. Okay? Now, up until about 5 or 6 years ago, we only had 2 types of medicines that could be used to delay progression of kidney disease in diabetics, and particularly type 2 diabetics, and to some extent the type 1 diabetics, but more effective in type 2 diabetics. And those were drugs classes called ACE inhibitors or angiotensin receptor blockers. Now,
like lisinopril or
losartan as an ARB, or like valsartan or ramipril. These names are probably familiar to a lot of your listeners. There was a time when it was thought that maybe using the 2 classes together would be beneficial, but that was refuted because we were seeing more episodes of acute kidney injury and more high potassium. So it's either one or the other.
That's an interesting point. I've had patients who I've sent to nephrology because of the GFR was really poor. And I had them on a controlled blood pressure regimen using an ACE inhibitor or an ARB, maybe something else like a vasodilator or a calcium channel blocker or whatever. And the nephrologist took them off of the ACE. Sometimes I don't know whether to keep them on or take them off or what. I said, why did they reduce that? I don't understand. Is that something?
It's not common practice that would occur. I think if someone's been diagnosed with chronic kidney disease, that in general you're going to try to keep them on an ACE inhibitor or an angiotensin receptor blocker.
Okay.
Unless there was felt to be an acute kidney injury component to the presentation of that patient,
okay,
that might have been the reason.
I got you. Now, how about these SGLT?
So, fast forward from the late 1990s and early 2000s to the late 2010s, we now have 3 additional classes of medicines that can be used to delay progression of kidney disease in diabetics. The first one is sodium glucose cotransport inhibitors, or SGLT2 inhibitors, and you might recognize names like Jardiance or Farxiga or Invokana. These are the common ones that are typically prescribed here. These have been shown to delay progression of kidney disease by about 35% in patients who have chronic kidney disease, whether they're diabetic or not. So even though those medicines were originally created as blood sugar lowering medications, they really have found more efficacy in the realm of delaying progression of kidney disease, and before that, preventing hospitalization for heart failure and improving mortality in patients with congestive heart failure as well.
I've been using them more and more for that reason itself.
And that's what we're seeing overall, is that more patients are being put on these medicines because the data supporting their use is so robust.
I understand. I understand. That's why I started to think about putting them on even before I send them to you guys. How do they work? How does it control chronic kidney disease? Is it known?
Yeah, it is known. It's basically, it works on the renin-angiotensin system. It basically reduces the pressure within the kidney through a feedback mechanism that the kidney employs. And I won't bore you by going into tubuloglomerular feedback. But essentially they work in a lot of ways similar to the ACE inhibitors and angiotensin receptor blockers as the end result. But the studies found that these were added on to those medicines, and so they're able to provide a 35% reduction in the progression of kidney disease on top of what an ACE inhibitor or an ARB would do, which is delay kidney disease by about 20 to 30%.
How do you know it's reduced to 30%? Is there something you could see in the lab work that would tell you that? In other words, you've seen a reduction of 30% of the kidney disease by using SGLT.
So what we see, we would see anecdotally is the slope of the GFR decline starting to flatten out a little bit.
Got it.
Right? So if a person's losing kidney function at, let's say, 5 ml per minute per 1.73 meters squared per year per their GFR, and you get them on this medicine. Now, initially there can be a slight a decline in the GFR, but over time you're going to start seeing it either that curve flattening out, so that you're delaying progression of their kidney disease. It may go down to maybe they're only losing 3 ml per minute per year. So that's what we're seeing. We're seeing people stay in chronic kidney disease longer and not needing dialysis as soon as they might have needed it. And in the future, when initiating these medicines earlier, the hope is that we're going to see a lot of people that don't need dialysis, even though they were diagnosed with chronic kidney disease.
Got it.
There's a couple other medicines that I want to mention, Nick. Non-steroidal mineralocorticoid receptor agonists. So there's one called finerenone that has been shown to be effective in type 2 diabetics in delaying progression of kidney disease. And that was published a few years ago in the New England Journal of Medicine through the Fidelio study. And then now, as of last year, we see the GLP-1 receptor agonist semaglutide showing efficacy in type 2 diabetics and delaying progression of kidney disease and reducing protein in the urine through the FLOW study that was published in the New England Journal last year. So we really are in a much better position now in treating chronic kidney disease than we were even as recently as 7-8 years ago.
Wow. And then there's the autoimmune ones that you'd use with immunosuppressants. I know we could get into that, but I'm not going to go there. We talked about the SGLT2s. We talked about the GLP-1s. I just read an article about GLP-1s and fatty liver disease is also being reversed with that. That's non-cirrhotic yet. Unbelievable. Some of these new ones coming out are just amazing medications. So, a diet for a chronic kidney disease. Give me a brief overview of a diet you tell your kidney patients to do.
So, common question that we get asked, and people will often come to my office having looked up a renal diet, and they're all concerned about how much potassium they're taking in and how much phosphorus they're taking in. The fact of the matter is a lot of patients with chronic kidney disease don't need to be on a, quote, renal diet. They really should be focusing on making sure they're on a carbohydrate-controlled diet if they're diabetic, on a low-sodium diet if they're hypertensive, and focusing on that. My biggest fear when I impose more dietary restrictions on patients is that they often say, what can I eat? And I don't want to restrict what they're eating because there's a lot of healthy food that they may avoid. For instance, we know that potassium is most prevalent in fruits and vegetables. I want my patients to eat lots of fruits and vegetables, and then I can monitor the potassium levels, but that's part of a healthy diet, not only for their blood pressure, but for their diabetes and losing weight.
If you find that potassium elevate, there's ways to lower your potassium.
Absolutely.
Medication-wise. Okay. I often see in moderate to severe chronic kidney disease, I see that the patient is anemic because we talked about erythropoietin in the earlier part of this discussion and how that goes to the bone marrow stimulating red blood cell production. And you give injections of that stuff, don't you, if you find that is the common cause?
Right. So the first thing we do when we see anemia in a patient with chronic kidney disease is to rule out other causes of anemia.
Correct.
You want to make sure they're not iron deficient or deficient in B12 or folate. And you want to make sure that there's no other reason for the anemia like a bone marrow problem, like a bone marrow cancer like multiple myeloma, which can cause anemia and chronic kidney disease at the same time. Once that's ruled out...
colonoscopies, make sure they're not bleeding that way, etc. Okay.
So by the process of elimination, we can then deem this anemia could be related to the kidney disease, and this medicine, the class of medicines is called erythropoietin-stimulating agents, and they are genetically identical to what your kidneys make to tell your bone marrow to make blood. But when your kidneys aren't working as well as they should, they're not making enough of that erythropoietin, or EPO for short, and then the bone marrow gets lazy and doesn't make enough blood and you become anemic.
Correct.
So we give that in the form of an injection. It's usually given once every 2 weeks or even as far out as once a month, depending on the formulation you use. And we try to keep the hemoglobin at least above 9. Some people shoot higher, but we try not to push it above 11. That is because when you push the hemoglobin up too high, there was an association with strokes. We haven't seen that in this range at all. But the big thing is it's prevented the need for blood transfusions in our patients. And why is that important? It's because if you're getting blood transfusions, you're accumulating antigens in your body, and that's going to make it more difficult for you to get a kidney transplant, which is the gold standard of treatment for kidney failure still to this day.
Got it. All right, let's shoot on down. We know what chronic kidney disease is, some of the causes, some of the treatments, but it gets to the point where it's end stage. No matter what you do, it's end stage. The kidneys have failed. And you're right there on the dialysis border versus the transplant border. What makes you... I have patients who are waiting for a kidney, and it's a long process, and they want a person to be almost like a perfect person except for their kidneys to get that transplant. Why is that? I mean, they're a little bit overweight, so they tell them you got to be ideal weight. Why is that? I know they don't want the kidney transplant to fail, but Is that the only reason?
It's not the only reason. I think they want to make sure that the patient is going to get through this process of getting the surgery done and then handling the immunosuppression, which also includes steroids in a lot of cases, well without having vascular complications. Transplant centers, I can tell you, are becoming more and more liberal with their BMI cutoffs.
Okay.
I've seen that occur. The country has a nationwide initiative to start increasing kidney transplants, and part of that means you can't keep throwing organs away just because there's something wrong with them. For instance, here locally and even across the country, the treatment of hepatitis C has become so effective and so well tolerated that those patients who could be a deceased donor for a kidney but had hepatitis C, that in the past that organ would be thrown away. Now we're using that organ. We can give it to a patient who doesn't have hepatitis C. The patient, the transplanted patient, may then develop hepatitis C, but then we put them on 12 to 16 weeks of treatment. Hepatitis C is gone, and they have a new kidney. And so there are so many advances going on within kidney transplant. So it's a very exciting time right now, and hopefully we're going to see a lot more people not have to endure as much time on dialysis as they have been.
Got it. And you also have now how you do hemodialysis. I know patients, when you mention that, they just their face just drops. They feel rejected. They feel hurt. They don't want to go through having this done 3 times a week for 4 hours. It's just not part of their lifestyle they wish to do. Tell me a little about hemodialysis. Do you get a lot of resistance? Are there easier ways to do it?
Absolutely. This is one of the toughest conversations we have to have with our patients. And in large part, it's because our patients are often scared. When you're facing a diagnosis of kidney failure, patients automatically kind of think about hemodialysis. Hemodialysis has gotten, not the best profile in the media and the public.
Bad rap.
The court of public opinion. But I will tell you that, and this is one of the things my partner says, this is a therapy that's cost-effective and replaces the function of a failed organ and can keep you alive for years.
Correct.
There's no other organ where we have something like that.
You're right.
That you can artificially replace its function and keep the person alive for years. Now, the question becomes at what cost, at what extent to the patient? So, fortunately, technology has improved so we can offer different types of dialysis. So when people think of dialysis, like you said, 3 times a week, you go to a center that's called in-center hemodialysis. And that's still the most common way in which dialysis is delivered in this country. But we, as a specialty, and the country is really trying to promote the utilization of home dialysis. Home dialysis can come in 2 forms. One is hemodialysis, as people get in the center. The most common machines that are used are smaller machines. They tend to be less efficient than the big machines in the center, which means that you need to do the dialysis more frequently. But there's an added benefit to that. If you're doing dialysis more frequently, you're removing fluid more regularly. You don't have to take as much fluid out each time, and that's better for your heart. Your heart's not getting shocked 3 times a week because we remove 3-4 liters of fluid out of your body.
Gotcha.
You're also getting better control of your electrolytes, and you're doing it on your schedule in your home. So you may decide that we're going to do it 5 times a week for 3 hours, and I'm going to do it Friday morning, but I'm going to take the entire weekend off. I'm going to go somewhere. I'll come back Sunday night and do my treatment in my house at that time. And so I think this whole concept of home dialysis does a lot of things. Number one, it can provide better outcomes at the outset. It can keep the heart healthier and gives patients freedom to do it when they want to do it. The other home dialysis is peritoneal dialysis. That's a non-blood dialysis that you do when a catheter is put into the abdomen and you instill sugar water in and out. Now, you can do that manually with 2-liter bags typically, or through a machine called a cycler, which will do it automatically for you at night. So, it is a matter of what you think is most appropriate for you, but patients really do better when they receive this education earlier on knowing what their options are. Mm-hmm. And the last option really is, as we're seeing a lot of patients who are older and maybe in their 80s and even 90s and developing late-stage kidney diseases, whether you want to do it at all. When you talk about quality of life, dialysis I would consider to be more of like a part-time job. You do have to commit a fair amount of time to it. For some patients, they're just not going to feel well with dialysis. And then the question becomes is, well, are you going to have more better days not doing dialysis than if you did dialysis? And that's a serious conversation that the physician should have with their patient by looking at all the different medical problems that they have and what their life expectancy will be and but most importantly, what are the patient's goals? And that's such an important conversation to have before we go down the dialysis route, because you have to really cater the therapy to what their goals are in life.
Has anyone ever said to you, I don't want dialysis, just let me go?
Yes.
And how long does it take for the end to happen? And is it a terrible end? I hear uremia is just you fall asleep. Is that true or not?
When someone's very advanced with kidney disease, so this doesn't happen overnight. Mm-hmm. Usually doesn't happen over the course of like a week. It's, slowly progressive over months, if not years. But yeah, kidney failure is not a painful
way to go.
Uremia is a situation where these toxins are building up in your body, but they don't cause pain. Primarily cause you to become more lethargic. You may have some itching. You may start getting, distaste in your mouth, metal taste in your mouth. But really, it is not painful.
Okay. All right. Now, just don't think we'll wrap it up now. Give me the details. You need AV fistulas to do hemodialysis, and for peritoneal dialysis, you just have a peritoneal. Now you have a hemodialysis unit. You say that's at home. It's a little one, and they do their dialysis. Can they do it overnight? And in other words, not waste their whole day at home. Can they do this process overnight?
So both peritoneal dialysis and hemodialysis can be done overnight. Okay. You just have to make sure that you have. Especially with the hemodialysis, you need to have a care partner there with you, because someone needs to be there in case the needles become dislodged. Now, that's not an issue with peritoneal dialysis and non-blood system. Mm-hmm. So, but it can be done at night.
Anything you want to add? I think we covered the subject pretty well, don't you?
I think so. The only thing I would say is we've got more options now to treat kidney disease and hopefully prevent people from ever needing dialysis in the future. We're not entirely there yet. Inevitably, some patients will progress, but even for those people who progress, as long as we can continue to take a patient-centered approach by incorporating their wishes and tailoring the treatments around that, we'll be in good shape.
Prayus, when people come into me, I find that they have a GFR that's abnormal. They have hypertension, diabetes, whatever. Do they know it? Do they have symptoms, or don't they?
Oh, Nick, that's a great question. Most patients who have kidney disease don't know they have it, and they don't have any symptoms, especially in early stages of kidney disease. Mm-hmm. So it really is incumbent upon the patient's primary care physician or primary care provider to be keeping an eye on the kidney function by looking at the GFR and referring them to a nephrologist when appropriate.
I like to see that. When I see my patients on their yearly physical, I obviously order kidney functions with the regular panel. And I see that their GFR from last year has gone down. And I know that their creatinine is elevated at that point too. And I say, I could add a SGLT. I could do a GLP-1. I could do all of that. And an ACE or an ARB or whatever. They might have been on it already. But I like to send them to you guys at an early stage, only to have them in the loop. Because if, God forbid, that patient who has a mild chronic kidney disease all of a sudden has an acute problem that develops more kidney injury, you guys know the patient. You already had seen them. You know what the cause of their original problem was, and you can address it quickly. Is that smart to do it that way?
I think that's a very appropriate management technique for patients who have kidney disease.
Okay.
The earlier they get in, the more we can educate them about what this means, and then that way we can reduce their anxiety levels about it and create a follow-up plan. And it may be as little as just pop in once a year.
Okay.
Or maybe it's more frequent than that if we find that there's risk factors for progression, like a lot of protein in the urine or some other form of kidney disease that has a tendency to progress more rapidly. But,
Got it.
Yeah, what you're doing seems right.
Well, Prayus, this has been a very interesting discussion. I think we educated the people out there. I learned a few things on my own when I researched all of this that I had forgotten and coming back to it. And I appreciate this discussion. It was very good. Now, how do people learn more about nephrology if they think they have a problem, and about you and your associates?
So the National Kidney Foundation is a great resource for education regarding kidney disease. It's simple web address, kidney.org.
Okay.
And if you want to find out more about my practice, Nephrology Associates, just go to delawarekidney.com.
Very good. This is Dr. Nick Biasotto, finishing our discussion with Dr. Prayus Tailor on acute kidney injury and chronic kidney disease. Hope you enjoy it.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Minton. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the host or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.